Hello, this is Rodney Horton. I'm a member of Texas Cardiac Arrhythmia Institute in Austin, Texas, and I was asked to present a case of percutaneous aspiration of the left atrial appendage thrombus. The case I'm presenting is a 64-year-old female with persistent AFib. She status post ablation, which included isolation of veins as well as isolation of the left atrial appendage. She has a history of hypertension and diabetes. Because of her gender and comorbidities, her CHA2DS2-VASc score was 3. And of course, on top of that, the patient's appendage had been isolated previously. The patient was now suffering from GI bleeding while taking therapeutic doses of apixaban, 5 milligrams twice a day. Because of the bleeding history, the patient was initially scheduled for Watchman appendage closure without anticoagulation. However, during the screening TEE, we were able to demonstrate a large mobile thrombus at the ostium of the appendage. Because of this, the Watchman closure procedure was postponed. The patient began NOAC therapy, and a repeat TEE was performed 6 weeks later. The second TEE, while on therapeutic anticoagulation, showed that the thrombus was still present and really had not changed. The patient was then transitioned to warfarin therapy with an intended higher target INR of 2.5 to 3. 2 weeks after initiating the warfarin therapy, the patient began having another GI bleed, which did require blood transfusion, and because of the urgency of the bleed, her anticoagulation was stopped and was actually reversed with FFP. A week later, she presented with a TIA. So now the question was, what are the treatment options? The patient had a recent GI bleed while on higher doses of warfarin therapy. The patient had a recent TIA during the brief cessation of anticoagulation and had a persistent thrombus while on anticoagulation as well as off anticoagulation, which was preventing traditional appendage closure. So the options that were available to us were a surgical approach. However, you'd have to understand that with an active mobile thrombus, this would involve sternotomy, cardioplegia, stopping the heart, surgically opening and physically removing the thrombus, and then closing the appendage either with a clip or perhaps with surgical excision or suture closure. There was, however, a percutaneous option that we explored, and this was to place embolic protection and then have a transeptal access and then actively remove or evacuate the thrombus with suction, followed, of course, by percutaneous closure of the evacuated appendage. In this case, we opted for the second of those. Here is an example of the first TEE. Now, this was while the patient was not on anticoagulants, and all of the subsequent pre-procedure TEEs looked very similar. By the time we decided to pursue a percutaneous treatment plan for this patient, this was her on the table intra-procedural TEE. If anything, the thrombus, while still present, actually appeared to be almost completely filling the appendage and did appear to be bigger than it had been before. So this was an example of the embolic protection that we used, at least part of it. This is called a Sentinel device. It's made by Boston Scientific. It's placed in the right radial artery. You do need to use an Allen test to make sure the patient has adequate ulnar flow so that there's no risk of injury to the hand. The way it's placed, there is a large proximal filter that is placed in the innominate, and then a distal filter, which you then bend it back and torque it around, use a angioplasty wire to engage the left carotid. And once you can see the angioplasty wire in the carotid, you pull, foreshorten the device, deploy the distal smaller filter, which covers the left carotid entirely. Now, when you use this embolic prosection, the one thing it does not entirely cover is the left vertebral artery, but that's the only thing to the cerebral vasculature that's not covered with this. Now, here is the transeptal that was done. If you look carefully in the bottom right, you can actually see the thrombus popping in and out of view. Bit unnerving to see during a transeptal puncture. In this case, we used RF energy to get across so that we wouldn't bow the septum any further toward the area of concern, in this case, the thrombus. That's going across. And then very carefully, once we had the sheath across, we clocked it so that it would be pointing posteriorly, and with TEE guidance, gently placed it into the left superior pulmonary vein. Now here is what we decided to do for rapid evacuation. The left video is to place a Watchman sheath, which is a 14 French thin-walled sheath, into the left superior pulmonary vein, and then pull it down and place it into the appendage for evacuation. However, here is a demonstration of evacuating from the side port of the Watchman sheath. As you can see, it takes at least 5 or 6 seconds to pull 60 cc's, roughly the contents of the appendage, into that side port. There's just too much fluid resistance to get a rapid evacuation. So what we decided to do is place a very large, thick-walled 6 French sheath through the hemostatic valve, and then once that was through, pull, and once that's through that valve, rather than pull to the side port, we pulled through the major orifice of the sheath and could actually evacuate 60 cc's in under 2 seconds, which is less than 1 heartbeat. So here's our sheath that's positioned in the left superior pulmonary vein, and we're gently pulling it back and counterclocking, which will put it in position. Okay, it's right in front of the clot right there, and we immediately evacuate. This took 2 people. So one person with 2 hands has the 60 cc syringe, and when ready, evacuates immediately. And as you can see, the clot disappeared. This was the clot. Once we had pulled it into the 60 cc syringe, you could actually feel vibrated resistance as the clot was slowly getting sucked into the syringe. And then we expressed it out of the syringe onto a white towel. And that was the majority of the at least solid contents of the clot. Once that was evacuated, then we used that same sheath to engage the now vacant appendage, and we placed a Watchman 2.5 device in the recently evacuated thrombus-filled appendage. And this was the final view of the appendage that was now filled with a Watchman device. Thank you.